Hi, everybody. My name is Peter Lorenz, and I'm a third-year medical student at Chicago Medical School. Today, we're going to be talking about HIV mortality across the 30 biggest U.S. cities, assessing overall trends and racial disparities. So with the introduction of highly active antiretroviral therapy in 1996, there was a very large decrease in total HIV mortality, but a corresponding increase in the Black-white HIV mortality disparity at the national level. But this national data masks very significant local variation in both of these metrics. And this is important because many public health decisions are made at the local level and are certainly implemented at the local level. We thought it particularly important to look at cities because HIV is primarily an urban epidemic, with 95% of HIV positive individuals living in urban areas, and we were unable to find any current studies that compared HIV mortality rates and disparities between different cities. So the goals of this paper were to examine HIV mortality rates for the 30 largest US cities, to assess the Black-white racial disparities within these HIV mortality rates, and to compare these two data points at two different time points, with time point 1 being 2008 to 2012, and time point 2 being 2013 to 2017. We found the 30 largest cities using 2013 census data. We found the cause of death files from the National Vital Statistics System that were stratified by age, race, and place. We included cases where the cause of death was listed as B20 through 24 under ICD-10 codes, and these are causes of death secondary to HIV infection. Our mortality rates are reported at deaths per 100,000. We did age adjust everything to the 2000 standard population, and if there were fewer than 20 case-specific deaths for any race group, we did exclude that data point. So what did we find? We found that total HIV mortality significantly declined in 26 of 30 cities and in the US as a whole, and that cities tended to have higher HIV mortality rates than the US average, which was 2.7 per 100,000 and 1.9 per 100,000. The city with the highest HIV mortality rate was Baltimore at both time points, which was 26.6 and 15.2. And the city with the lowest HIV mortality rate at both time points was San Jose at just under 1. So what did we find when we looked at disparities in HIV mortality at time point 2? That no city had a rate ratio of less than 2, meaning that in every city studied, Black residents die from HIV at least twice the rate of their white counterparts. That the national rate ratio of almost 10 was actually higher than all of the cities studied, which ranged from a high of 8.5 in Jacksonville down to 2.3 in San Antonio. When we look at the race-specific numbers, the Black HIV mortality rate at the national level is 8.6. The city with the highest Black HIV mortality rate is Baltimore at 21. The lowest was Columbus at 4.5. We look at the white HIV mortality rate. The national rate is 0.9 per 100,000. The city with the highest rate is San Francisco at 11.5. And the lowest rate is Charlotte at 1.1. The trends in disparities were much less clear than the trends in HIV mortality, with only the US as a whole and Charlotte, North Carolina showing a significant change, and both of them decreased. We then grouped cities into best and worst performing along these two metrics of mortality and disparities. And as you can see, there's a very wide spread between all of these cities along both of these metrics. The best performing cities were Indianapolis, San Diego, Columbus, and Phoenix, and the worst performing were Jacksonville, Houston, and New York. And of note, we were only able to include 22 of 30 cities in this analysis. So what do we take away from this? That the Black HIV mortality rate is still persistently higher than the white rate, ranging from 2 to 8 in the cities we studied and increasing up to 10 in the US as a whole. But we also found really high variability in both disparities and mortality rates between these cities. And this points to the non-inevitability of high mortality rates and of high disparities. And this can provide strong motivation and insight for city and local leaders who are looking to share best practices and improve their continuum of care in their communities. And these are in line with some national goals, such as those laid out in Healthy People 2020 and 2030, the National HIV and AIDS Strategy, and Ending the HIV Epidemic, A Plan for America, all of which specifically list reducing HIV mortality disparities as priorities. Our limitations is that we did have to exclude certain cities due to the limited number of race-specific deaths. The concern that HIV mortality overall may be underreported, and particularly among minorities, meaning we could have understated the degree of these disparities, and that we had to limit our analysis to just Black and white disparities. I want to thank you so much for joining us today, and I hope you enjoyed this presentation.